being with us until the last. But the most pivotal session of the day, because that's the session when we are launching our flagship report, World Heart Report. This year, the World Heart Report is focusing on obesity and CVD. And it is my pleasure to give the floor to Johanna Rausen. You have the report there as well after the session. Johanna Rausen is a long-term global advocate for non-communicable diseases, the current CEO of the World Obesity Federation, past CEO of the World Heart Federation, and previous VP of the American Cancer Society. She's also a lived experience advocate. Johanna, over to you.
Thank you so much. And so thank you for, this is the last, and might I add, the best session of the day, because we are actually, it's really interesting, exciting topic, and I personally love when things converge. I love that John Harold came up to me yesterday and started talking about the work that, the convergence of cardiovascular and obesity. It's incredibly interesting, especially for people like us who are so passionate about this. But again, this report is really a great tool. One of my staff and our board president, Simone Barquera, contributed to it. Please do get a copy in the back, because it's very comprehensive with great recommendations, and I think just really distills very well the complexity of the interlink between the two. So without further ado, we are going to get going. We're going to try to get to the panel a little bit quicker. Sorry, but I should probably ask everybody to turn their phones off and do the same myself. Apologies. This is a little embarrassing here. I don't have my glasses, so it's like my mom is calling. No, my mom, yeah, I live in the U.S. now, although I work in London, and it's partly because my mom has dementia, so I do get calls at strange times. I usually remember to turn it off, but it's all fine. Anyway, so thank you so much. It's wonderful to be here. Wonderful to see old friends and new friends. And I am going to just say a couple of quick things. One, we're very excited about having all of these speakers together, and I want to really get to them and get to hearing from them and having them talk to each other. So we are going to ask them to come up very quickly. Francisco Lopez Jimenez, could you come up? Francisco, is chair of preventive cardiology at the Mayo Clinic. Dr. Pamela Cipriano is president of International Council of Nurses. Maria Chiara is here. Okay, she is professor of population studies and global health at University of Essex. Professor Fausto Pinto is head of cardiology and heart and vascular at the Santa Maria University in Lisbon, and a past president of World Heart Federation. And last but very much not least, Professor David Wood, who is professor of medicine at University of Galway and also a past president of World Heart Federation. So without further ado, Francisco is going to start us on the Pacesetter lecture, and then we will go into some questions. One plea that I always make before you start is if we could try to use person-first language. You'll see that in here, where we really talk about people with obesity. Unfortunately, obese is a word we've needed to reclaim. It has become pejorative in many ways, but I think describing people with obesity shows that they're more than just the condition or the disease itself. So again, just a plea, if you may. Thanks. So please go ahead, Francisco.
Thank you, Hannah. It's a pleasure for me to be here. And without any further introductions, well, it turns out that obesity is not a problem of high-income countries anymore. As we know from the most recent audit on obesity prevalence, that about 900 million individuals live with obesity, and that is about 4 times the number of people with obesity we had in 1990. It is projected that in 25 years, 2 out of 3 people will live with overweight or obesity in the world. And right now, obesity carries a very significant economic burden, accounting for about 2 to 3.5% of the GDP of the world, and just in the USA, it accounts for 10% of the GDP. The health impact is also tremendous, as we know that about 3.7 million people die as a direct consequence of obesity, and half of them will die with cardiovascular disease. Now, this presentation could be just based on statistics, and the report could have been just on numbers and all the terrible things that we know about the epidemiology of obesity, but at the very beginning we decided to make this report more cardiovascular focused and also with a message of hope and recommendations about interventions. And the beginning of it is related to the pathophysiologic relationship between obesity and cardiovascular disease. So we know that there are numerous disease mechanisms linking cardiovascular disease and obesity, as you can see right there. Obesity creates a hyperadrenergic state, subclinical inflammation, increases insulin resistance, makes some hormonal disarrays, causes left ventricular hypertrophy, and many other abnormalities that eventually would lead to other risk factors like hypertension, diabetes, dyslipidemia, and obstructive sleep apnea that all, in conjunction with the disease mechanisms, will lead to numerous cardiovascular conditions. It's important to say that obesity is not just a risk factor for all those conditions that you see right there, but it's actually a causal factor for all those. So it's not just a risk factor. And obesity is traditionally linked to coronary disease, but we know that obesity is one of the major, if not the major risk factor for heart failure with preserved ejection fraction. Obesity can cause dilated cardiomyopathy, can lead to sudden death due to ventricular arrhythmias, is one of the most important risk factors for atrial fibrillation and hypertensive heart disease. We also know that up to half of the patients with cardiovascular disease live with obesity, and that 1 in 10 individuals with cardiovascular disease will die as a direct consequence of obesity. Now, historically, obesity has been labeled as a lifestyle condition, and that's something that we believe has to be reconsidered. And it's important for many reasons, but one is because it is not that simple. And the second reason is because the label of lifestyle as a lifestyle condition can actually lead to barriers for treatment, to bias, and also to withdraw treatment to some individuals, as we learned the lesson from the AIDS epidemic that was originally labeled as a lifestyle disease. Now, why do we know that obesity is way more complex than just a lifestyle condition? Well, because we know that there are environmental, health, biological, and socio-demographic factors that lead to obesity. And just to give you some brief examples how that works, for example, psychological factors. We know that about 40% of women with morbid obesity were sexually abused before developing obesity. We know that people who had major life events are also way more likely to develop obesity than those who didn't. We know that poverty is one of the major risk factors for obesity in many countries, whereas in other countries, being rich is one of the major risk factors to develop obesity. We know that obesity can be predicted based on genetic markers, because up to 70% of the obesity predisposition can be traced to the genes. Health issues also lead to obesity. For example, individuals who were born with congenital heart disease are 3 or 4 times more likely to develop obesity than individuals who don't. And the reason is because as children, they were protected not to move around, not to exercise, not to be active, whereas they were served the same amount of food as the siblings, and therefore, over time, they develop obesity. And we can go on and on and on how the environment, genes, socio-demographic factors can lead to obesity. And I can tell you that it would be extremely unusual to find a person with overweight or obesity that will not have one of those factors in their history or present. And that is why, despite the fact that many clinicians and the society in general will simply say that people with obesity are lazy and have no willpower, that is not the case. It is also important to highlight that there are significant sex differences in obesity in relationship to cardiovascular disease. For example, the prevalence of obesity is higher in women than in men in many countries, particularly in Latin America, the Caribbean, in Africa, the Middle East, and Southeast Asia. That obesity provides a higher risk for diabetes in women than in men for the same BMI. And for the same waist-to-hip ratio, women are more likely to develop cardiovascular events than men. We also know that women have a higher obesity attributable cardiovascular risk, and that obesity in women is a major contributor for the cardiovascular disease-related disability-adjusted life years, or DALYs. Now, in this report, we provide recommendations, and we divide the recommendations as those that are based in the clinical arena and recommendations from the public health standpoint. From the clinical standpoint, we believe that it's important to destigmatize obesity by educating the newer generations, medical students, nurses, and healthcare professionals that obesity is not always a choice. Actually, that's probably the exception and not the rule. We also need to empower healthcare professionals in how to treat obesity by teaching in medical school and in other forums elements of evidence-based treatment for obesity. We need to expand the access to weight loss medications, surgeries, and behavioral interventions because sadly, about half of the patients undergoing treatment for obesity these days actually pay for that out of pocket. And the reason is because obesity treatment is rarely covered by most health insurances or national health systems. And despite that most of those health insurance companies or health systems will pay for expensive cardiac interventions like stents and surgeries and so forth and so on. We believe that it's important to build multidisciplinary teams because physicians alone or nurses alone or dietitians alone cannot handle the amount and the burden of obesity in the clinical arena. We need multidisciplinary teams including doctors, nurses, psychologists, dietitians, experts in behavioral health, and so forth and so on. We also need more digital tools to be implemented to scale the treatment of obesity. We also need cardiology guidelines to incorporate evidence-based recommendations for the management of obesity. And very importantly, to incorporate more and more details on the complexity of the relationship between obesity and cardiovascular disease. Why? Because the presence of obesity affects the care of cardiovascular conditions and vice versa. The care of obesity is affected by the medications we use in cardiovascular care. For example, we use beta blockers in many patients with cardiovascular disease. Beta blockers can lead to weight gain or can make it very difficult to lose weight. By the other hand, the presence of obesity affects the metabolism of many medications we use in cardiovascular medicine, like some oral anticoagulants. So we need to be familiar with all those complex interactions. Otherwise, patients with obesity and cardiovascular disease will suffer. From the public health interventions, there are many interventions that have proven to be good to either prevent or to treat obesity, including community-level interventions, such as urban planning, designing better streets, walkable streets, green spaces for people to be more active, eliminating food deserts, by helping people to have access to cheaper, healthy meals, and helping schools to provide healthy meals. Just in the United States alone, up to a few years ago, 99.5% of the schools were serving extremely unhealthy and obesogenic foods in the whole country. That is improving, but still a lot to be done. In regards to policy interventions, we know that policy can change access and also help to curb the obesity epidemic. We know that taxating unhealthy foods and also subsidizing healthy foods drives choices among people. Other interventions like the food labeling and also increasing access to treatment will be important. In this report, we also recommend several things like taking advantage of the WHO and the Heart Federation frameworks that I will list a few in a minute. We believe that national societies, cardiovascular societies, and other medical societies need to really create national roadmaps, and at the same time to work on scaling up equity-focused and evidence-based interventions similar to the ones that I listed before. And in all this, we have to engage people living with obesity in the planning and the implementation of all those strategies. Now, I mentioned some global initiatives to address obesity and cardiovascular disease. The WHO has created 4 of those. You can see those, and those are reviewed in more detail in the report. And also, the United Nations created the Decade of Action on Nutrition that is ending this year, and the WHO is coming up with the technical package to stop obesity. So we can use those resources as we create national plans and regional plans to treat obesity. Finally, we also provided some recommendations to improve research and data gathering. Before that, we humbly recognize the need to have more data. We know that we don't know many things that cause obesity, because if we knew it, we would not have the problem we have right now. We need to humbly recognize that there are many gaps of knowledge. And in spite of the high expense that obesity brings to many countries, or most countries, the amount of money that is spent in obesity research is just minuscule. We recommend that we need to have more data from more regions of the world. We have some data, but it's not enough. We also recommend that we need to do more research on the potential benefits of weight loss and obesity treatment, reducing cardiovascular risk. In the last 4 or 5 years, we have obtained tremendous pieces of information proving that weight loss can indeed prevent cardiovascular events in many patients living with heart disease. We also recommend to prioritize implementation research, because there are some interventions that we know work. We just don't know how to implement those interventions the best. We also recommend more research on childhood interventions to curb obesity, and also supporting the training of individuals willing to spend time and a lifetime in research careers dedicated to obesity. And finally, we'd like to thank everyone who participated in the creation of this report, particularly Professor Marichiara De Cesare and the other 16 authors, as well as the reviewers and the editor. Thank you very much.
Excellent. That was excellent. Thank you very much. We're going to jump right in and ask Fausto now a question, so that sort of taking this into the practice. In your clinical practice, how does obesity, a patient with obesity, affect the outcome of their CV treatment? What are some adjustments that you need to make, and how do you manage that sort of dual challenge? Thanks.
Well, thank you so much, Joanna. It's really a pleasure to be here. And first of all, let me reinforce again the importance of this report. Some of you were not at the beginning when Joanna showed it. It's going to be distributed to all of you. And this is actually probably one of the best pieces that we at WGF provide. And use it. It's free. It's open access. It's on the web. And please use it not only for yourself, but for your community, regardless of you are a healthcare professional, you are a patient representative. Very important, the data. And Francisco just showed you a little bit of a flavor of what you can find here, but very relevant. The other thing, the message I want to leave here is that the management of obesity, it's going to be one of the biggest revolutions in medical management, in the medical address that we will have as a medical community and as a community as a whole in the next few years. I have no question about that. And as many other conditions, the big change was when we first recognized obesity as a disease. And it took a while. And even today, there's a little bit of challenge in terms of, is it a disease? Is it a life, as you've mentioned, is it a lifestyle problem? Today, we have clear definition by WHO. WHF also follows that definition that obesity is a disease. And this is very important because we are dealing with a condition that needs to be managed and approached as a disease. Of course, there are many factors that are implied, and some of them have been shown, but this is one of the key factors if you want to be successful. From a clinical standpoint, and now as a clinician, as a cardiologist that takes care of these patients, the fact that we have now medication, that we have now ways to deal with this condition in a more efficient way. And of course, we need more data, we have to support research, we have gaps in knowledge, all of that, but we already have evidence or some evidence, and that's why I think what is on the report is very important because this is actually, it's going to impact on the guidelines. I have also no question about that because we do have robust data, trials with drugs that have an impact not only in terms of obesity itself, but for instance in the cardiology field, in the heart failure group, we already have a couple of trials that clearly show the impact in that regard. Therefore, the management of obesity now from a cardiology perspective, it's always been an issue, it's always been a problem, it was always very difficult to manage, but now we do have this open opportunity to be able to use different strategies and different ways to be more efficient in dealing with the condition, with the disease, with all the implications that we have seen. And it's very important that overall, all of us can actually have, of course, the data to have do it properly with all the relevant aspects that can be used in different ways, and also very importantly the which actually applies to all other conditions, the education from the population to the healthcare professionals, to the medical community, so we can actually have these concepts getting into the management of this condition in a very efficient way, because we do have tools now that can help us to manage obesity. So, and going straight to your question, from a clinical standpoint, I think the main difference now is the fact that we can use now tools that we didn't have just a few years ago, and that with results, with evidence, that can actually help us to manage a condition that has major implications in the cardiovascular condition of our patients.
Thank you very much. That was a great comment. Okay, so Pam, turning to nurses, what do you see as the role of nurses? How is that changing in the prevention and management of obesity? And tell us a bit about some of the elements of that.
Yeah, thank you. So actually nurses have been involved in looking at the care of patients with obesity for 25 years. And although it may not be widely recognized, when we think about nurses' interventions and working in teams and working with patients related to cardiovascular disease, what we often think about is, well, nurses are diabetic educators, and that's been a very, very successful model over the years. But some of those very same skills, I think, are very important in terms of we look at how nurses now are interacting within the practices and in their conversations with patients. We have to recognize, first and foremost, nurses are the most trusted healthcare professionals worldwide. And so there is a real comfort level, if you will, that often can develop in the relationship between a patient and the nurse, where the patient may be a little bit more intimidated by the physician as part of that team. But I think a couple things that are important to recognize. There has been discussion, obviously, this afternoon about primary health care. The goals of universal health coverage are to boost primary health care, and that also means having the right workforce. So internationally, we're really looking at how do we place more nurses in primary health care? How do we make sure that care is integrated? Because if that's where patients are presenting, that's where patients need the education and support, then we need to put more nurses in primary health care, which is often the case in low and middle income countries, but not in high income countries. Where high income countries, the nurses are further away, they're mostly in hospitals, and they're not doing the primary care interventions that are really needed. It goes back to the money issue that we also heard discussed in the last panel. But one of the differences in terms of how nurses can be the most effective in terms of education, nurses know how to use motivational interviewing. When we think about this population of people who are already, in many cases, being exposed to stigma because of their size, or again, are afraid to be able to talk about having a weight issue. Again, I think this is a place where nurses are making a significant difference. The other piece that when we talk about the clinical and the public health issues, nurses bridge both of these areas. In terms of the clinical, again, whether it's part of the history taking, of understanding the social determinants of health, the conditions that present, whether it's an issue of not being able to afford care, or whether it's all of the other issues around food deserts and poor transportation systems and not enough green space and not enough activity in our schools to be able to encourage movement and encourage healthy eating. Nurses are able to get that information from our patients to really be able to create that collective plan in terms of recognizing what are the precursors, what are the causative factors that really need to be taken into account, particularly as we think about, again, trying to have therapeutic lifestyle modifications. Those are not easy. I mean, we can talk about it as much as we want, but if you're the individual who's having to make those choices and changes, it can be very, very challenging. So nurses, again, are well positioned, whether it's dealing with our children in schools, where that is a primary point of contact where they can be very influential, but again, also needing to take into account what's happening with that family, or whether it's in the community settings where they are ambassadors of trying to also make change to make sure that communities, whether it's through the urban planning changes or whether it's really looking at specific neighborhoods and where people are presenting, what are the issues that they have, that we really need to be paying attention to. One last area, though, that you may not be recognizing or aware of is nurses are very involved in using digital technology to help patients in many chronic diseases. And specifically, we have an example of a study from Spain, small study, but 66 patients, 2 paired groups, where the nurses, in terms of being able to provide additional education, additional follow-up and support through a platform, were able to get statistically significant reductions in weight, waist circumference, BMI, and adherence to the therapeutic plan. So there are some great ways that I think, again, we're using now current tools to be able to be more effective.
Thank you so much. So now we've heard 2 people say they think obesity is a disease. We have others who are still coming along on that or think it's just a risk factor. The zero draft of the political declaration for the high-level meeting seems to think it's just about prevention, really. And so that is a continued challenge there. David Wood, what do you think? as a preventive cardiologist, tell us what you think. What's your view?
Well, obesity is very easy to define. It's weight over height squared, and that's called the body mass index. In fact, actually, it was a man called Quetelet, a mathematician in Belgium, who first produced this formula in order to characterize his local population. And now we use it as body mass index, and we divide it into these categories of 15, 20, 25, 30, and so on. But actually that's very crude because this is a continuous variable, and at any given level of BMI, there is a given level of risk of, say, diabetes or a given level of risk of cardiovascular disease. So it would be more appropriate to express any measure of obesity in relation to their ultimate risk. But even that is too simplistic because as adiposity increases, so blood pressure rises, the person becomes more dyslipidemic, low HDL, raised triglycerides and so on, and more dysglycemic, impaired fasting glucose, impaired glucose tolerance, or frank undetected diabetes. And so when you put all of this together as a composite, you get a much better expression of the meaning of adiposity in terms of their overall cardiovascular risk, and that's what we should be addressing.
Great. Thank you. If you've not seen it, there was a Lancet Commission on clinical definition of obesity that came out earlier this year that sort of addressed the need for more than just BMI because of the limitations. So, for example, New Zealand rugby players have higher BMI. You know what I mean? Those things, needing more, and where does it cross over into pathology? And it's a very complex. I commend that report to you. I think it speaks to some really interesting approaches, including having preclinical and clinical, or sort of preclinical and clinical obesity are some different ways. But Maria Chiara, can I ask you for some comments about this, based on your own work?
Yeah, thank you. And I think that if it's possible, I would like to do a step back, in the sense that so far we have been thinking about the diagnosis, the treatment, the disease. But in fact, from the public health perspective, that is a step too late, because the person already has the disease, already has the condition. So it's really to think what we can do upstream to really tackle the wider determinants of health. So if we really are serious in tackling obesity, we really need to think, and cardiovascular diseases, we need to think about those wider determinants of health, and what we can do to avoid that so many people. Just to remind, we have 900 million adults with obesity, and if you add the 150 million children and adolescents, we are talking about over 1 billion people that are living with obesity. So it's really thinking what we can do together as a community to tackle those wider determinants of health. So what is that is bringing people to have that condition? So that can go, Francisco has mentioned some of those, right? That can be the social, the economic, the psychological, the environmental determinants. So what can we do really at that level, for me, is a question that we should pose, because otherwise we are always behind tackling obesity. We are always a step behind. Right. So I think in the report we also try to tackle and we present some data that show the sex differences, the education, the urban-rural differences. So we have seen, for example, that rural areas are where BMI is increasing faster than what we observe in urban areas. So in some cases, the gap is closing between urban and rural areas. So, and that is a matter of access to healthy diets, access to physical activity, access to safe space, because we need to think about physical activity, whether your neighbor, the area where you live, allow you to be safe outside, right? So I think that for me, it's really, as a public health, more on the side of public health, is really thinking how can we work together within the system and try to tackle all these aspects. So that can go from community intervention to health system intervention. This morning, a lot of people have mentioned obesity this morning, so it's not something that is just in the report, right? So for me, it's really thinking what we can do. And then, once we get downstream, we remain with really the people that needs and have the condition, have the disease, and need to be diagnosed and treated and managed. So for me, it's really thinking about that aspect.
If I may, I think this is very important, because we have two levels of action. One of them is at the public health level, and that's what Maria Chiara just mentioned. But let's not forget that we already have almost 1 billion people with obesity, and we have to take care of those. So actually we have to go in parallel. On one hand, of course, we want to tackle the condition at a very early stage, from the womb of the mother, I would say, to the schools, and have that action so we can actually prevent the development of the condition, as much as we can. But at the same time, we have to take care of the people who already have the condition. And you're absolutely right, and that's a problem that we actually face with cardiovascular diseases. Many times, or most of the time, particularly we as cardiologists, when we see the patient, it's already too late, because the patient already has a condition installed, many times already with complications, acute MI, stroke, whatever. So I would say that, I agree with what you said, but we should, and that's the challenge, of course, and it's a societal challenge, how we're going to deal with these different aspects, because of course managing a condition It's not going to be, and we've spoke a little bit about health economics and so on in some of the previous sessions, and that's going to be a challenge for the society. But let's keep in mind that, and let's focus on both. On one hand, upstream for prevention, but we already have 1 billion people that have the condition, and we have to manage them, and that's going to be our challenge.
Absolutely. Francisco, do you want to comment on that and kind of?
Yeah. Expanding on that will be also to recognize the complexities that patients with cardiovascular disease and obesity represent. At Mayo Clinic, we actually have to create a cardiometabolic clinic, and the only reason is because our patients were not being treated appropriately because general internal medicine, endocrinologists, and other areas will feel afraid treating patients with cardiovascular conditions because for them they were too sick to get medications for obesity. And not only that, the patients also were in the middle of the cardiovascular care and the obesity problem because for cardiologists, obesity was such a mundane condition to spend time treating that would not even bother to initiate the treatment. So we believe that that we have to pay attention to obesity in general, but in particular patients with cardiovascular disease because they are not being served in many places of the world.
Those are the high risk, you know.
Yeah, absolutely, David.
There's a banking corporation that advertises itself on the walkway as you get on the plane with aphorisms like, is it a midlife crisis? No, it's an opportunity, and other things which are equally asinine. But on the plane coming to Geneva, it was society shapes us as individuals, and then we as individuals shape society. And I thought that was very apposite for this topic because we're not speaking about the elephant in the room here, which is that we are facing the most powerful forces which are driving the obesity epidemic in the form of, writ large, the food industry. And they are producing highly processed foods, wonderfully palatable, some would say addictive, high in fat, sugar, and lots of salt, and so on. And this is the driver at a societal level of the obesity epidemic. And that's your biggest, our biggest challenge, is how you address that industrial force. But then on the other hand, we have, as individuals, the pharmaceutical industry riding to our rescue, because now we have GLP-1 receptor agonists, and they mimic incretins, and so we produce more insulin, and gastric emptying is slower, and we feel fuller, and we eat less, and as a consequence, we lose weight. And so Fausto is right that for individuals, we have rescue close at hand, and thank you very much for those who have developed these medicines. But that is not the answer. The answer is political.
Okay. I would like to invite people to, if they would like to go and stand at the microphone, if you have any questions from the audience. And do you have any, you had a comment you wanted to, while you're going up there, if anyone wants to come up here. Do you want to, do you want to just stand there? Okay. Yeah. Yeah.
I was sort of broad. I happen to be interested in that field for the last probably 20 years, thanks to the World Heart Federation assigned me a talk in Dubai at the World Congress. Cardiovascular adiposity is not just a scaffold. So since then, I got interested in that field and we studied already over thousands of patients. Obesity is not only just what you see in your belly, that has a different messenger RNA than obesity around the heart and the kidney. So cardio-obesity is the major risk factor. And we have studies shown that obesity without cardio, visceral adiposity in the belly, without cardio-obesity have less structure and function abnormality, versus when the obesity around the heart, the cardio-obesity by itself showed more structure and function. You have to differentiate. Obesity or fatty tissue is the largest endocrine organ in your body. Once they get big, the adipocyte, they produce this atherogenic hormone and become more, including the local angiotensin. So really we have to look at obesity as an endocrine organ and 3 different types. Subcutaneous, that's the white. Visceral in the belly, which is brown, and around the heart, the inhomogeneous, and around the kidney.
Okay, thank you.
Well, I think this is a good comment because it shows the complexity of obesity that Francisco was starting to show a little bit. I don't think we have time to get into all the details, but you're absolutely right. You know, pericardic fat is actually been demonstrated in many studies showing that it's actually a marker and a risk factor because of all the reasons, inflammation and so on, that will trigger some of the events that will happen in this patient population. That's correct.
Great, thank you. Did anyone else want to respond to that or to one another?
I just have an unrelated comment, and that relates to some of the things that we have been discussing about the role of prevention, which obviously I think we all here agree that prevention is really the key. But it's also important to recognize that I think we have done some things in the wrong way in the medical community. For example, a lot of focus has been placed on exercise and not so much on physical activity, when in reality is the non-exercise activity day to day that really makes a difference. The main difference between a person with obesity and a person with a normal weight is not necessarily the amount of calories they eat, is not necessarily the amount of exercise they do. It is usually the amount of activity that is unrelated to exercise, because that might amount to 900 calories per day, whereas you go and run for half an hour the fastest you can, and you can barely burn 400 calories. And 500-600 calories a day will add up, you know, a number of kilos per year. So it's also important to recognize that even in the medical community, the focus on the prevention hasn't necessarily been targeting an intervention that is way more efficacious.
Well, you know, I think the beauty with that is recognizing how important the health histories are and understanding at a detailed level, even having patients create diaries of their activity, of their meals. Can they even remember what they ate in the last 2-3 days? I mean, having that individual, because we did already acknowledge how important it is to keep that lived experience as part of understanding how it is that we have personalized, person-centered care, and that we coordinate that care based on that individual, their culture, their family situation. But I think, too, it's not a one-size-fits-all in terms of assessing those risks. I think, really critical points.
Yeah, absolutely. Did you have something you want to say, Maria Clara?
No, I think, I totally agree. And if there is a question on the
sorry, I apologize. Did you want to ask something? Yeah.
Hello. Actually, I just wanted to make a comment, if that's okay. I've waited till 5 o'clock in the afternoon, so I might as well. My name is Magdalena Decor, and I'm Chief Executive Officer of FH Europe Foundation. It's a network of patient organizations, and I wanted to say how much I appreciate this panel, because I think all aspects, the 360 has been really addressed, from the fact that we live in a society that is maybe pushing towards certain behaviors or societal determinants, as well as opportunities that we have addressing them with therapies. But it's boiling down to the citizen, to the person, and really understanding that health literacy starts very early in the family, in the community, and just like Professor Wood said, there's a lot of things that we can do, but we need to really include the citizen. And what I just wanted to sort of leave this statement here with is the fact that World Heart Summit is a fantastic opportunity and a platform to bring the stakeholder that we keep talking about. We keep talking about the disease, but it's actually the humans, the people who live with that. And it's not like us here in the room and the world outside. It affects all of us. So I think making sure that the perspective of the person, the patient, is as well represented, so they're part of the change, part of this solution, rather than someone that is being talked about. But I really appreciate and I really enjoyed this particular panel, because a lot of those things can be employed across all the CVD risk factors and CVD as such, not just obesity. So thank you.
So it sounds like there's an enormous amount of alignment across obesity and cardiovascular disease, particularly around the determinants, and that's a great point. So I think what I would like to do is ask each of you to do your final sort of 30-second comment in terms of what do you see as kind of the most important priority for aligning efforts, and then, or not, and then I'll just close it out, and that'll be the end of it. So we know it's 5 o'clock. What do you think?
I can start maybe
Yeah.
just the 15 seconds is that I think we need to really work, think about the health system and integrate action to tackle obesity and cardiovascular diseases without leaving anyone behind, because this is the other problem, that what can happen is that our intervention or the access to diagnosis, treatment, management, and also the rest is not equitable distributed across the population.
Thanks.
I think, Joanna, that we may have lost some generations and may lose yet more, despite the fact that there are now pharmacotherapies which will help people to lose weight. I think we have lost generations already, and therefore my priority would be children and young people.
I would say that let's work to reduce the burden of obesity, because by reducing the burden of obesity, we're reducing the burden of cardiovascular disease.
Very much so.
To be a little bit repetitive, I do think we need to start with children. We need to start with primary prevention. But we also have that billion people that are suffering with the disease. One of the things that hasn't been mentioned is we still have on that continuum of treatment surgery. And I think we need to rethink the prioritization and the efficacy of the different types of treatment to really look at how do we retool those clinical interventions. And again, this is a long-term project. And the other piece is I think because we know we should be affecting the marketing of poor food choices and things like that. So I think we're calling on this whole community to not only really evaluate what we need to change in what we do, but also become politically active in terms of affecting social policy.
Yeah, my last words will be that not only the importance of not only considering obesity as a chronic condition, but in the patient with multimorbidity, where obesity is one of the 5 or 6 conditions, to analyze that case one by one, because in many circumstances, very likely obesity is going to be the upstream, the root cause, and the downstream conditions will be many of the others. When we start seeing that relationship and not just being in a horizontal, being obesity one of the others, we can actually think about prioritization of treatment and how focusing on that might bring benefit to all the other conditions.
Great. Yeah, I think we believe in the obesity community now that we could probably hit SDG targets on NCD prevention, premature mortality reduction, if we effectively started with obesity more than we are. So this has been great. One thing, I just want to say one thing that came to mind. When people hear that I work at World Obesity Federation, either they hide their food, like I'm going to scold them, which is like, I like potato chips, okay? But also, I always get the questions, is it about food or is it about health? Is it about, poverty or wealth? Is it about, this or that? And I say, yes. It's about all of those things, and we need to get out of our yes. And I think that cardiovascular disease is so much the same way. You can't just treat your way out of it, and you can't prevent your way out of it. You need to be doing things together. So, and we did have one wonderful partnership with World Heart Federation, creating training modules with our program, SCOPE, which is mostly an online training program for healthcare professionals. We have a core learning path on cardiovascular disease and obesity, and Francisco Lopez was part of it, and there was a position paper. This was published a couple of years ago, I think about 3 years ago. But we do have some resources that are available. If you want to learn more about that, let me know. And there definitely needs to be more research, training, and activity. But thank you. It's been wonderful. Thanks. And thank you to our great speakers.